I would like to invite our chairpersons for the next session on recent advances, Dr. Mary D. Cruz, Dr. N. Bhavatarani and Dr. Malayakanti Das. And our first speaker for this session is Dr. Jayanta Panda. He will be speaking on the role of comprehensive metabolic panel in diabetes diagnosis. I request the chairpersons and speakers to please come on the dais.
Thank you. Thank you for the wonderful scientific feast. Very good morning, all. Without wasting much time, we are already running late. We'll move on to the most awaited recent advances. In that we are having the wonderful person, Dr. Jayant Panda, who has his own style delivering. Over to you, sir. That is about the role of comprehensive metabolic panel in diabetes diagnosis.
Thank you, Bhavatarani ma'am. Thank you, Dr. Patni, the man behind this show. And I'm very happy that the Dwra movement has reached so far. The topic assigned to me is very simple. Many times when you are in front of a patient, you think what test to write, because diabetes affects from head to toe. So how to go about the problems, which is a complete, comprehensive metabolic panel, and how scientific we are in advising that to our patients. So here's something which was suggested, a basic minimum 14 tests as a comprehensive metabolic panel, came in guideline, came in electronic medical record, and depending on the complications and the situation, you can expand it further. So you know the diabetes is increasing, and also in country it's a big problem. And we have the diagnostic criteria of fasting 126, postprandial, random or casual or post-glucose 200, A1C 6.5 as diagnosis, and in between the normal and this as the pre-diabetes criteria to revise your understanding, 5.7 to 6.4% A1C, 100 to 125 fasting and 140 to 199 pp is pre-diabetes. And we have to consider the pre-diabetes equally with importance like the diabetes, because they are prone to complications and we predict the complications in them. So comprehensive metabolic panel is a 14 different substances provided overview of metabolic and organ function and routine screening tool in clinical practice. They include glucose, calcium, electrolytes like sodium, potassium, chloride and bicarbonate, renal markers like B1 and creatinine, proteins like albumin and total protein, and hepatic markers like AST, ALT, ALP and bilirubin. As simple as that. All of you know these are all basic tests and you prescribe, but at times you may leave one, like calcium few people don't advise, bicarbonate few people don't advise, and say albumin and protein routinely we are not doing. So that's why this list came, the difference of basic versus comprehensive metabolic panel, and this whole list of 14 tests were included in comprehensive panel, and these 8 tests were in the basic panel. So the rationality and the indications I'll just touch upon. The guidelines supporting the comprehensive metabolic panel use, and ADA recommend, and the comprehensive metabolic panel is included in annual diabetic evaluation, enhancing the preventive care. In the personalized medicine also, this is tailor-made based on the organ function, because not only diabetic, the diabetic complications are indicated, optimizing safety and efficacy. The last thing, the electronic medical record system, which most of your clinic and hospitals have, they are enabling to train the tracking and flags the abnormal parameter, improving the clinical workflow. The reason why we have taken this 14 tests. The interrelation of diabetes and hypertension are known to many, that the insulin resistance, the sympathetic stimulations, the smooth muscle proliferations, they come. And invariably a diabetic develops hypertension and a hypertension patient develops diabetes. So this system mediated by rash and sympathetic nervous system, inflammation and the oxidative stress and insulin resistance tells us the different organs and their safety and the complications. They affect the kidney, they affect the heart, there are of course microvascular complications affecting the renal, nerves, food, the peripheral vascular disease affecting the macrovessels and also the coronary arteries and the cerebral arteries. So this common pathway to be detected early, we have a panel called Comprehensive Metabolic Panel. The MASLD, you are all aware that it's a diabetes equivalent at present. The hepatic fibrosis, cirrhosis, hepatocellular carcinoma, the decompensation, and the insulin resistance, hypoglycemia, incident diabetes with atherosclerotic cardiovascular disease, they come in hand. Along with obesity, the hepatic steatosis, the fibrosis, the risk increases with indeterminate risk, and the cardiovascular, the renal and the endothelial affection are very common in obesity, diabetes, hypertension and atherogenic dyslipidemia. The side effect of the insulin and the diuretics, we use a lot of thiazide diuretics like chlorothiazide, the hydrochlorothiazide, the metronidazole, the dopamine. They increase the sodium, potassium, magnesium, decrease the calcium. Loop diuretics increase all electrolytes. And potassium sparing diuretics like spironolactone, eplerenone, the amiloride and trimethoprim, they decrease the potassium without any action in sodium, magnesium and calcium. And we know about the potassium shift out of the cell in hyperosmolarity, exercise and the cell lysis, and potassium coming inside the insulin and the beta agonists. So this simple picture tells you why you should test the electrolytes. The major side effect of antihypertensive medications, you know, ACE inhibitor, ARB, responsible for hypokalemia, and we monitor very carefully in acute kidney injury, withdrawing temporarily if there is hypovolemia, besides there is cough and angioedema. The calcium channel blockers, the peripheral edema, headache and flushing takes place. Thiazide-like diuretics, I already talked about the hypokalemia, the gout, the withdrawal, temporarily hypovolemia is there. The MRAs, the mineralocorticoid receptor antagonists, cause hypokalemia and the gynecomastia. We know the new drug, phenynon, launched. Only contraindication is potassium more than 5. The beta blockers, there can be bronchospasm. Alpha blockers, there can be postural hypotension, and in all these side effects, you can monitor because the patient is on one drug or other. Similarly, insulins causing hypoglycemia, sulfurias, hypoglycemia, glutazones, precipitating congestive heart failure, and then SGLT2 inhibitors like the amputations, DPP4, the pancreatitis, GLP1, the retinopathy and the pancreatitis, alpha-glucosidase inhibitor, again the hypoglycemia and metformin lactic acidosis. This is a complication of the drugs. So it's not only the disease, not only the complications, this is the effect of the drugs used for the hypertension and diabetes that also detected by this comprehensive metabolic panel. So in diagnosis, in screening and in monitoring, all three phases, the comprehensive metabolic panel can help us. The limitation of the traditional markers, we discussed about the markers. The A1C may be affected by the hemoglobinopathy. We know that the anemia and the ethnicity, Fasting and OGTT require fasting and patient compliance. Do not provide information about the electrolyte disturbances, organs like liver kidney function, acid-base imbalances, and the risk of misdiagnosis in earlier atypical presentations. So traditional markers are silent about that. And comprehensive metabolic panel, few things I'll tell before I close. This is a panel test which I've already told you. The glucose, calcium, sodium, potassium, chloride, protein, albumin, creatinine, BUN, and the carbon dioxide, that's bicarbonate, alkaline phosphatase, alanine aminotransferase, alanine aspartate aminotransferase, the ALT and AST, and the total bilirubin. As simple as that. You will think that this misses many things because A1C is not there, OGTT is not there, but very mindfully they have selected this for the diagnosis, for the complications, and for the broad effects. The purpose is the systemic insight into metabolic health, detecting early and organ involvement, electrolyte imbalances, and guiding therapy and monitoring diabetic complications. Beyond blood sugar, it offers a broader metabolic snapshot. It's not that only diabetes. It detects early organ damage, electrolyte imbalances, like in the MSLD and the CKD. Important is the diabetes often asymptomatic at diagnosis, and like you detect hypoglycemia, you have to detect the electrolyte abnormalities as well. And this comprehensive metabolic panel helps assessing systemic impact of the hypoglycemia. Clinical utility is the useful in high-risk screening, the obesity, hypertension, the family history, detecting undiagnosed hypoglycemia, identifying early renal and hepatic complications. The glucose measurement, the diagnostic role is the key for diabetes screening, 126 and 200 I have told you. Limitation is we are not doing A1C, OGTT, and any patient where the glucose is high or more than 200. 200 is a simple value in postprandial, post-glucose or casual. More than 200 tell you about the diabetes possibilities. And the clinical relevance is incidental hypoglycemia and CNP, uncover the undiagnosed diabetes and valuable in routine checkups and diabetic monitoring. The electrolytes, common disturbances, sodium, potassium, chloride and bicarbonate, reflecting the acute states like diabetic ketoacidosis, hyperosmolar, hypoglycemic state, and the clinical impact is reflecting dehydration, acidosis, renal impairment, and guides insulin therapy and fluid management. The advantage is rapid overview of the electrolyte and acid-base starters, critically for emergency and inpatient diabetes care. The renal functions matters because it's a leading cause of CKD, and the kidney damage is often asymptomatic, and the comprehensive metabolic panel, the BUN and the creatinine assess renal function. Elevated levels indicate declining glomerular filtration rate, which is important, along with the albumin creatinine ratio that we do recently. The diabetic nephropathy is detected early, supporting the staging of CKD and guiding for the medication as well. Similarly, the hepatic function, the relevance strongly associated with non-alcoholic fatty liver disease, and the comprehensive metabolic panel includes the ALT, AST, ALP, bilirubin and albumin, and hepatic steatosis or hepatocellular injuries prompted, the clinical utility detecting the hepatic involvement, and important for the patients on hepatotoxic medications. So calcium and protein levels matter for nutritional status, bone health, and the calcium levels may be altered in renal impairment, total calcium, albumin and protein. Just 1 minute. Total calcium, albumin and total protein, they come into picture identifying hypoglycemia linked to CKD and insulin therapy. So these comprehensive metabolic panel and the detection of comorbidities like multi-organ involvement and screening tool and clinical utility is very important. Routine monitoring helps adjusting therapy and the frequency, and the advantage is comprehensive view, cost-effective and clinical impact. Limitation is not a standalone diagnostic tool, non-specific findings and interpretation requiring clinical correlation. So TechWay is a valuable adjunct in diabetes diagnosis and monitoring, providing comprehensive metabolic overview, detecting complications early, help tailor management by assessing renal, hepatic and electrolyte status, and should be used in conjunction with specific diabetes tests like A1C and OGTT, and facilitates the holistic patient care and improves clinical outcome. For the practitioners, those who need a guide regarding what to tell patients every year for a test, it's just complete. I'll tell you, this 14 test, if you have noted down, is just complete, and they are designated comprehensive metabolic panel, and if you tell that, beyond that any specific requirement can be added, but this tells about the diagnoses, about the complications, about the drug effects, and predicts the future course of the patient. Thank you again for the invitation and the attention I have got during my presentation.
Thank you, Dr. Jayanth. You have exhaustively explained everything. It's not just a mere rise in blood sugar, it affects the entire thing from head to foot. And don't wait for the drugs. We have plethora of drugs, but even after taking treatment, how it affects all the other metabolism out of it. And I just want to note here that our father of diabetes, Professor Dr. Vishwanathan, maybe 3 decades before, he came out with that. Even before this, that is at the stage of 1 hour and post glucose. He called it as early glucose intolerance and alerted everybody by doing so many studies in the whole members of the family. We had it like that. Now we'll move on to the next, that is, let us have an overview of the CBO trials in the pipeline. The new news in the field of cardio-metabolic disorders by our Dr. Manish Agarwal.
Good morning, and first of the thanks to the Dr. Patni sir giving the fantastic platforms. After our opener batsman Dr. Jayanth Pandey sir, I am going to talk of the next 15 minutes of the CVOT trials under the pipeline in 2025 to 30. That is one of the very challenging of this particular cardio. And what is cardiometabolic disorder? And India is a capital of diabetes. At present, we are having more than 140 millions are diabetic, and more than 160 millions are pre-diabetic. Every yearly pre-diabetic population, 25% of the pre-diabetic population are going to convert into a diabetic population. And now India is a capital of the diabetes. Why is not my purpose, my target, India should be capital of the cure of the diabetes. You can see of the diabetes does not come alone. Diabetes always is a blood pressure, cholesterol, obesity, overweight, dyslipidemia, and pre-diabetes. These are some of the, I am going to talk this particular. You can see of the burden of the metabolic disease, of the non-communicable disease, of the diabetic 140 millions, pre-diabetic 160 millions, and diabetic and pre-diabetic populations almost 240 millions. Hypertensive, almost 2/3 of the diabetic patient is hypertensive, and generalized obesity, Indians is a typical obese, or BMI is not so high. But compare, we are more in particular the visceral fat rather than subcutaneous obesity of the hypercholesterolemia. We are seeing, unfortunately, Indian genetically our genes, our phenotype, we are having the low HDL with the high TSG and high LDL cholesterol of this particular. Now I am going to focus on the cardiovascular outcome trials of the CVOT. I is a large rigorous design clinical studio with evaluate the cardiovascular safety, efficiency of the new drugs, especially population who are high. Already diabetic, pre-diabetic population, they are more prone to 2 to 3 times more prone to all the cardiovascular accident and as well as cerebral vascular accident. Focus on the cardiovascular events. CVOT typical focus on the primary outcome of the major adverse cardiovascular event. MACE3 is contain the non-fatal acute MI, non-fatal stroke and cardiovascular death. And phase 4, we are getting the head of the heart failure and fifth point we are going to add the hospitalizations for the unstabilized. And these are pipelines of the sum of a study. These are fantastic studies going to pipeline. We already started in 2020 and now is going to the 2026, 25th and 6th in the coming months. In the study of the tracer rate, compared with the Dwra with all the major cardiovascular events with the type 2 diabetes, with a surpass COD, and this overview, previously I am going to talk, purpose of the trial, to assess the efficiency, safety of this particular, the beautiful molecule of the tracer rate to the liraglutide with the type 2 diabetes who are having the established coronary artery risk. Clinical effect of this tirzepatide versus the liraglutide with the major adverse cardiovascular events in the patient with a type 2 diabetes, and conditionally drugs you can see of the 1-to-1 head-to-head are ultimately almost more than 30,000 patients will take, and next month it is going to the again is a study of the tirzepatide is compared with the molecules of the liraglutide on the major cardiovascular events with the type 2 diabetes. Outcome, what will be our outcome measurement? Type 2 first occurrence to the death from the cardiovascular cause with the acute MI with the stroke MACE-3, and time to the occurrence to the component of the MACE-3, and time frame is almost 54 months of this particular study of the test of the again is a survodutide on the cardiovascular safety passengers who are overweight, BMI is more than 30-35. What about the CV outcome of the phase 3 randomized double-blind parallel event-driven cardiovascular safety with the administered subcutaneous compared with the placebo with the overweight BMI established the coronary artery disease on the chronic kidney disease. Of all the diabetic patients, we are getting the green for ACR test. Actually, these are some of the 2 risk factors of the CVD, and outcome measurements, which is a time to first occurrence to the adjust the component and composition of the end of the CV death, not fetal MI, and ischemic, and ultimately phase 4 is a heart failure. And measurement prescription heart failure include the hospitalization for the heart failure, emergency room, urgent care, and urgent outdoor patient heart failure using this particular, and up to this study is going to up to the week of the 114 of the study overview of the study obeys of the submont of the MMO, previous study of the phase 3 randomized double-blind placebo controlled study trial with the tirzepatide reduction of the motility and morbidity with the patient's diabetes with the obesity and overweight. You can see some of the arms of the tirzepatide with the drugs, and study has been started in 2022 and is going to complete it after the 5 years or 2027 phase 3 internationally. Almost 50,000 patients were taken of the study of the tirzepatide of the reduction of the morbidity and motility with the type with the obesity of the measurement of the submont of the MMO is a continuation of this particular up to the 5 years already I have discussed. A redefine of this. These are again the pipeline research study to efficiency of the cargicimab with the patient is having the heart blood vessel disease. Redefined 3. Previously, study will look after this molecule on cardiovascular events. An example in the heart attack, stroke with the exiting the cardiovascular disease. Patients get this particular combinations of this of the molecules of the cadmicima with the dummy additions with the placebo. You can see of the drugs is of the cadmicima drugs is a semaglutide 2.5 mg. Placebo study has started in 2023 and going to the completed in 2027. Almost 7,000 patients were taken. Phase 3 international study, and ultimately this found of redefined research study to see the effect of these molecules on the patients having of the living disease with the heart and vascular macrovascular complications, and time to first occurrence to the major adverse cardiovascular events. Composition endpoint consisting CV death, not fetal stroke, and measured in day and baseline 0 and further to 42 weeks. And again is one of the very fantastic study of how evaluated of the MRA is a finger rod of the clinical efficiency and safety of the heart failure. It is one of the heart failure pillar out of the 4 of this one. Study overview. The finger rod can be compared to the placebo and determine the efficiency and safety of the treatment with the heart failure. You who are having the reduce the ejection fraction, intolerance to the other ACE inhibitor, ARB, of the because of hyperkalemia and some of the cough and this or angioedema, we can put on this particular finger on of this particular detailed prescription, international, randomized, double-blind, placebo-controlled heart failure with the reduce the ejection fraction, and obviously outcome randomized, double-blind, placebo and prophetic study to evaluate the phenomenon of the clinical efficiency and safety with the heart failure and reduce the ejection fractions of this one. You can see study has been started in 2024 and is going to complete on the end of the year, end of the 2028, or almost 2,600 patients were taken internationally phase 3 of this particular study. The study to evaluate again is going to the continuations of the fentanyl is a very fantastic molecule of the heart failure or having the reduction, poor the injection infections of particular. The time to initiate time to first occurrence, cardiovascular, heart failure, number of the serious side effect, events, number of the adverse effect leading to discontinuous of this particular time to first CV death with heart failure with the fentanyl compared with the placebo, and serious adverse effect of the fentanyl with the compared with the placebo, and number of the adverse effect discontinue of the investigation molecules whatever these are 30 months of the. These are a phase 3 study investigated. Everybody is knowing this for heart failure with the cardiovascular death with the combinations with the SGLT inhibitor with the prevent the heart failure with the fantastic molecule of the Baxter-Strain. A brief summary: in a patient participant, male, female, what about the age of above 40, type 2 diabetes, stabilize the coronary artery, history of the hypertension, systolic blood pressure should be more than 130. That was a screening of the, and we should monitor the blood sugar, potassium and electrolytes, at least of the one risk factor of the heart failure. These are some of the screening criteria. Study will include the options of the pre-screening period to the felicitate the site identification of the potential eligible participant to enter the full screen assessment, and participant will be not required to visit the site, and that can be telephonically conversation of the already study has been started in 2025 and end of the study to expected in 2029, or almost 11,000 patients were taken of the phase 3 international study of this particular. These are again molecules with outcome to the heart failure, reduce the risk of the heart failure, events and severe death, and time to first occurrence to the any component of this hospitalization heart failure can be reduced when we are going to combinations of the both molecule heart failure without hospitalization and severe death and events driven up to this particular study of the 38 10. Study of this particular again is going to the instrument to prevent the stroke, and clot is a particular who are having the neurologically ischemic attack. Most of the diabetic and pre-diabetic is inflammatory, hypercoagulatory stage. They are more prone to the neurovascular events of the multicentric, international, randomized, placebo, controlled, double trial, parallel events, phase 3 with the oral factor 11 to prevent the ischemic stroke, either male and female, age of the 18 of the and below 65. You can see outcome. You can see up to the study up to the 30 months of the and randomized trials of the effect of this particular the PC kinase of the clinical outcome, were the oral study of this particular the Cynthia of the atro and the atherosclerotic cardiovascular and placebo, ultimately they found out the fantastic. One of the combination of the EMPA and DAPA is empathy is a very good who are heart failure of the preserve, reduce the ejection fractions. This study has been started in 2022. Is going to complete in this particular 2025 of the end of this year. phase 3 prognosis of that was showing of the very fantastic reduction of the hospitalization for the heart failure of the study of the, again I am going to shortage of the time, study of the insignia to prevent the cardiovascular events with high risk of the primary preventions of the time to first occurrence to the 4P wave and 3P point of the wave of the study of the cardiovascular studies of the Victoria 29s of the study. These are my last slide. And the arrowhead pharmacokinetic to enhance the RN base of this molecule phase 3 of the capital cardiovascular outcome trial. This cardiovascular outcome trial is a compared with the placebo. There is screening with 25 milligrams. Some of the patients were put on the placebo, ultimately that was found of the significant reductions of the cardiovascular death, not fatal MI, not fatal ischemic stroke, coronary revascularization, and major adverse outcome of the. Thank you for hearing me. Thank you. Any questions, sir? Thank you once again.
Any questions from the audience? Yeah, as well, running late also.
Thank you, Patti sir, giving the opportunity. Thank you, sir. Thank you.
If there is no question, we should conclude the session. Sir, please come to this side.
I would request the speakers and chairpersons to please proceed towards the selfie zone.